Hi everyone, welcome to researchmd.com. We have a great presentation today, and today we're going to teach you all about dysphagia under 9 minutes. We know how important the time is, time for you, so we want to make sure all of this, most important stuff is going to be covered under 9 minutes on most of our presentation. We're going to teach you in under 9 minutes, okay? Today's topic is dysphagia. Again, my name is Pramil, Cheriyath, the Program Director, Internal Medicine Residency Program, Transitional Residency Program. Also teach medical students, medical students and internal medicine residents also, okay? I'm also Director of Research. So let's get into dysphagia. Before we talk about dysphagia, there's 4 definitions you need to know. One is like a dynophagia, the other one is actual dysphagia, the other one is Presby dysphagia and globus hystericus, okay? Or dynophagia means like, painful swallowing, right? Dysphagia, that is what like, our topic today, like problem swallowing. And then Presby dysphagia, it's usually kind of seen in elderly people, okay? Because what happens when we all get older, a lot of our mechanism, like we lost the taste, we lost the muscle strength for chewing, we lost the smell also, and then there's always like a lot of fat deposition on the tongue. That all kind of affect the oropharyngeal phase most of the time. And then globus hystericus is that when you hear like some people always they feel like something it's in the a lump in the throat. That's what you always say, but there's nothing there. It's their feeling in their mind there is something there, okay? So if you look at this is the normal physiology, we got a nice diagram. We got oral preparatory phase, oral transit phase, pharyngeal phase, and the esophageal phase. The main thing you have to know is a couple of anatomical or like it take from almost up to 20 seconds for usually the food to reach esophagus. Okay. The other thing also you need to know is the dilatation or like when we eat. The esophagus kind of distended up to around like 20 millimeter size. So if it is become less than around 13, that's what we call stricture. So when the esophagus diameter is less than 13 millimeter, you can say there's a stricture going on, okay? So what are the causes? Again, too broad. Like first you have to know the oropharyngeal causes, and then you have to know the esophageal causes, okay? So we got like nice diagram up here. What are the difference between oropharyngeal and esophageal cases? In the oropharyngeal phase, it's usually patients start having complaints like right away. Remember, we said like the transit time from the food when we take it and reach the esophagus is around 20 seconds. In this case, they're like 1 to 2 seconds they started having problem, okay? They will usually kind of point towards the cervical region, some problem. If food is like having an issue right there when we are swallowing. There's always kind of regurgitation food. There's like aspiration. There's drooling of the secretion. Siluria is there. Dysarthria, coughing and choking. All these are like about the oropharyngeal phase. Now let's look at the esophageal dysphagia. Difficulty swallowing, and the time period is like, usually like around maybe 10-15 seconds after you initiating the swallowing mechanism, okay? When you ask, people usually kind of point towards the suprasternal nose or sternal. There's like food stuck in there, and there's always, they could have like chest pain, and they can have like heartburn, okay? So when you look at esophageal dysphagia, again, you have to put it into 2 broad categories. One is the solid only, and the other one is solid and liquid. When you talk about solid, it's usually in some kind of mechanical obstruction, malignancy, or it could be stricture, carcinoma, esophagitis, esophageal rings or web, and vascular anomaly, okay? When solid and liquid, that kind of tell us patient have like some neurodegenerative or motility disorders like achalasia, diffuse esophageal. In achalasia, remember the bird-beak appearance and the on the barium swallow. Diffuse esophageal spasm, nutcracker appearance, and esophagogastric junction outflow obstruction. We got ineffective esophageal motility, absent contractility, and systemic sclerosis or scleroderma, where like almost like 90% of the people have some kind of dysphagia problem, okay? So when you take the history and the past medical history, let's look at like what questions you have to ask. You need to ask her, what is the history? Do you have any history of this in the past? Because all of them can contribute to dysphagia. We put it into so many categories so we can easily remember. One is the neurological, stroke, multiple sclerosis, ALS, you got brainstem tumors, Huntington, Parkinson, All of this can cause us, you need to ask the history. Gastrointestinal, this is a peptic ulcer disease, gastric tumor, gastroesophageal reflux disease, eosinophilic esophageal, short-skin string, cardiovascular causes kind of mitral stenosis can cause atrial enlargement that can compress the esophagus, and you got aortic aneurysm or enlargement of the aorta, and you can, let's say, aberrant subclavian artery that can also cause us dysphagia. You have to ask the history of that. Always ask the endocrine history because thyroid enlargement compress, you know. And then you got autoimmune is very common, like we talk about scleroderma, like 90% of the people can have dysphagia. You can have Sjogren's syndrome, also dysphagia is very common. Myasthenia gravis, dermatomyositis, poliomyositis, and sarcoidosis. Infection causes mainly like CMV esophagitis, herpes esophagitis, HIV, Candida, and the cancers. Again, we talk about GI malignancy, brain tumor, and brain tumors, or all this malignancy also can cause like dysphagia symptoms. Okay. Now medications also, several medications called, mainly doxycycline is one of the most common antibiotic. We talk about NSAID, ibuprofen, oral biphosphonate, HIV medication, KC, potassium chloride, and even vitamin C can cause it. Always good to ask the patient history. Why? Because eosinophilic esophagitis can process like dysphagia, so you need to get a good history on the patient. Family history, always look for family history of cancer because we talk about the link with the esophageal cancer, gastric cancer, and the problem swallowing, and the brain tumors. And then social history, alcohol, smoking, and all of this can cause us like cancer, several problems like even esophagitis. Sexual history is important. HIV can cause like Candida esophagitis, CMV esophagitis. Syphilis can cause like gamma. And then psychiatric is important because, you know, it can present when you have globus history, because people, you know, you have psychiatric condition, they always feel like, yeah, I got something struck in the throat, like knob-like sensation. Let's go to the physical examination. What we have to do, you look at the eye exam, you look for anemia, because what is important? Because anemia, iron deficiency anemia, Plummer-Wilson syndrome, very important topic. Tongue hypertrophy, fat deposition in elderly, fasciculation less, oral cavity, look at dentures, tonsil ulcers, neck, you can look at the lymphadenopathy and the thyroid disorders. And hands, you look at the scleroderma changes, koilonychia, the iron deficiency, abdomen, aortic pulsation, and masses that can also cause us. In the labs, mainly, you have to also look at the eosinophilic esophagitis, and you let's check an ESR, CRP, autoimmune condition, and if there's anemia, do iron studies. And then important test you can do bedside is a 3-ounce water test. Okay, patient drink 3 ounces of water without interruption, and you look for the changes like, you know, sensitivity, and the negative predictive value is like pretty high. You have to, when you do the 3 minute swallow test, 3 ounce water test, you have to look for, is there any sound difference also in the patient. So negative likelihood ratio for the 3 ounce water test is like 0.11. And endoscopy first line, then you got barium swallow, you can do esophageal manometry if you're thinking more achalasia, esophageal spasm, and other investigation you can do CT scan, endoscopic ultrasound. Thank you so much for watching our presentation. We'll be back with another presentation. Please subscribe to our channel.